Renal transplantation. Donor nephrectomy, including cold preservation, open, from living donor. The physician performs an open donor nephrectomy from a living donor by removing one kidney and upper ureter for transplantation. To access the kidney, the physician usually makes an incision in the skin of the flank, cuts the muscles, fat, and fibrous membranes, fascia, overlying the kidney, and sometimes removes a portion of the 11th or 12th rib. After mobilizing the kidney and ureter, the physician administers an anti-clogging agent. The physician clamps, ligates, and severs the upper ureter and major renal blood vessels, renal pedicle, and removes the kidney and upper ureter. The physician administers medication to reverse the effects of the anti-clogging agent. After controlling bleeding, the physician irrigates the site, places a drain tube, and performs a layered closure. The donor kidney is preserved for transplantation into the recipient. The organ remains under refrigeration, packed in a sealable container with some preserving solution and kept on ice in a suitable carrier. Recipient nephrectomy. The physician removes the kidney and the upper portion of the ureter in a patient who is to receive a kidney transplant. To access the kidney and ureter, the physician usually makes an incision in the skin of the flank, cuts the muscles, fat, and fibrous membranes, fascia, overlying the kidney, and sometimes removes a portion of the 11th or 12th rib. After mobilizing the kidney and ureter, the physician clamps, ligates, and severs the upper ureter and major renal blood vessels, renal pedicle. The physician removes the kidney and upper ureter, but does not remove the adrenal gland, surrounding fatty tissue, or Gerotis fascia. After controlling bleeding, the physician irrigates the site with normal saline and places a drain tube, bringing it out through a separate stab incision in the skin. The physician performs a layered closure. Renal allotransplantation, implantation of graft, without recipient nephrectomy. The physician surgically implants a human kidney and ureter from a living donor or cadaver into a transplant patient, without performing a concurrent nephrectomy on the recipient. To access the transplant site, the physician usually makes a curved, right or left lower quadrant incision in the skin. After cutting the muscles, fat, and fibrous membranes, fascia, the physician controls bleeding with clamps, ties, and electrocoagulation. The physician surgically connects the renal vein and artery of the donor kidney to the recipient's clamped and dissected internal iliac vein and hypogastric artery. After removing the clamps, the physician checks for leakage, bleeding, and insufficient blood supply. To implant the donor ureter, the physician makes an incision into the bladder and passes the ureter through the bladder. The physician sutures the ureter as well as the opening in the bladder, cystotomy. The physician performs a layered closure. The drain tube may be left in. Renal allotransplantation, implantation of graft, with recipient nephrectomy. The physician implants a donor kidney and upper ureter after removing the recipient's kidney and upper ureter. To access the recipient's kidney and ureter, the physician usually makes an incision in the skin of the flank, cuts the muscles, fat, and fibrous membranes, fascia, overlying the kidney, and sometimes removes a portion of the 11th or 12th rib. The physician clamps, ligates, and severs the upper ureter and major renal blood vessels, renal pedicle, and removes the kidney and upper ureter. To implant the donor kidney in upper ureter, the physician usually makes a curved lower quadrant incision in the skin. The physician surgically connects the renal vein and artery of the donor kidney to the recipient's clamped and dissected internal iliac vein and hypogastric artery. After incising the bladder, the physician passes the donor ureter through the bladder and sutures the ureter and opening in the bladder, cystotomy. The physician performs a layered closure. The drain tube may be left in. Removal of transplanted renal allograft. The physician removes a transplanted donor kidney from the recipient. To access the rejected kidney, the physician usually reopens the original kidney transplant incision, and cuts the muscles, fat, and fibrous membranes, fascia, overlying the kidney. After mobilizing the kidney, the physician clamps, ligates, and severs the major renal blood vessels, renal pedicle. The physician removes the rejected kidney. After controlling bleeding, the physician irrigates the site with normal saline. The physician may place a drain tube, bringing it out through a separate stab incision in the skin. After removing the clamps, the physician performs a layered closure. Renal autotransplantation, reimplantation of kidney. The physician moves the kidney from its original anatomic site and revascularizes the kidney by connecting the renal and iliac vessels to a new site. To access the transplant site, the physician usually makes a midline transabdominal incision in the skin and cuts the muscles, fat, and fibrous membranes, fascia. After exposing the kidney, the physician clamps, ligates, and severs the renal vessels, keeping the ureter intact. The physician flushes the kidney with cold, anticoagulant electrolyte solution, and surgically connects the renal vessels to another appropriate arterial and venous site. The physician removes the clamps and checks for leakage, bleeding, and infarction. After placing a drain tube and bringing it out through a separate stab incision in the skin, the physician removes the clamps and performs a layered closure. Liver allotransplantation, orthotopic, partial or whole, from cadaver or living donor, any age. The physician performs partial or whole liver transplantation to the normal anatomic position of the liver in a patient of any age. The physician makes an abdominal incision. The diseased liver tissue is removed, hemostasis is achieved, and the liver bed is dried and prepared for the donor tissue. The donor liver is placed in the prepared liver bed. Anastomoses are created between the donor hepatic vessels and the appropriate recipient vessels. The donor bile duct is approximated to the recipient bile duct or to a limb of small bowel for drainage. Drains are placed and the abdominal incision is closed. Transplantation of testis, ES, to thigh, because of scrotal destruction. The physician transplants the testis, ES, under the skin of the thigh to preserve function and viability following massive injury or surgical loss of the scrotal skin. The thigh is chosen because the temperature just under the skin is approximately the same as in the scrotum, a condition to normal testicular function. Incisions are made in the skin of the thigh adjacent to the scrotum and the testis is sutured in place with attention to preserving blood flow to the organ. Transplantation of pancreatic allograft. The physician performs pancreas transplantation. The physician makes an abdominal incision. The iliac arteries and veins in the pelvis are exposed and isolated. An anastomosis is usually performed between the artery and vein supplying the pancreas to the iliac artery and vein on one side of the pelvis. An additional anastomosis is usually performed between the attached duodenal segment and the bladder. The incision is closed. Bone marrow harvesting for transplantation, allogeneic, autologous. This procedure is for the removal of donor bone marrow. The physician places a large bore needle into the marrow cavity of the sternum, iliac crest, or ribs. The bone marrow is aspirated with a large syringe and placed in a container. The puncture wound is covered with a dressing. Hematopoietic progenitor cell, HPC, HPC boost. This procedure is for the implantation of donor bone marrow or blood-derived peripheral stem cells. The recipient's immune system is first suppressed using radiation or chemotherapy. The harvested bone marrow or peripheral blood stem cells are injected into the recipient by intravenous drip therapy in a sterile environment. Report if the transplanted cells came from a donor other than the patient, and 38,241 if the transplant material is autologous and came from the patient. Leukemia patients who show molecular or clinical evidence of relapse after transplantation are infused with additional lymphocytes collected from their donor to help boost the graft versus leukemia effect. Report 38,242 if the patient receives an infusion of lymphocytes. Parathyroid autotransplantation. The physician excises and reimplants a portion of the parathyroid. The physician exposes the thyroid via a transverse cervical incision in the skin line. The platelets is divided and the strap muscles separated in the midline. Tissue is excised for separately reportable pathological examination. All 4 parathyroid glands are completely removed. 1/2 of one gland is secured to the muscle of the sternocleidomastoid or upper arm. The platelets and skin of the neck and transplant site are closed. Intestinal allotransplantation, from cadaver donor. From living donor. The physician performs an intestinal allotransplantation. The patient is placed supine on the operating room table. After adequate preparation, the physician performs a midline abdominal incision, tissue is incised, and muscles are separated down to the level of the small intestine. The area of small intestine to be transplanted is located. An incision is made through the intestine, the area is examined, and the free intestinal edges are debrided or excised in order to accept the intestinal transplant. The previously excised small intestinal allograft, from a cadaver, 44,135, or partially excised small intestinal allograft, from a living donor, 44,136, are removed from the maintenance solution, and irrigated. The allograft is sized and is anastomosed first to one free end of the patient's small intestine and then the opposite end of the patient's small intestine. Any bleeding is controlled, the area is irrigated, and the small bowel is anatomically positioned in the abdominal cavity. The wound is closed with layered sutures over a drain. A dressing is applied.